Welcome to the Brad Carr Podcast. My guest is Dr. Norman Doidge, psychiatrist, psychoanalyst, and researcher, and the author of bestsellers The Brain That Changes Itself and The Brain's Way of Healing. In this episode, we discuss neuroplasticity, the human brain's incredible capacity to heal and recreate itself, even after the worst of traumas. Dr. Norman Doidge, how would you describe neuroplasticity to someone who's never heard of it?
It's a property of the brain which allows it to change its structure and its function in response to experience, and that includes mental experience. So sensing and perceiving, even thinking, can allow you to change the structure and function of aspects of your brain. Movement, which you're always monitoring and acting in the world. And it's important because for about 400 years, scientists believe that the brain couldn't change except to deteriorate with age, that its structure was fixed, and there was basically what you might call, what I've called, a doctrine of the unchanging brain. And it arose because, first of all, we'd seen people sustain brain injuries or strokes, and they were devastating, and there were the number who recovered from serious brain injuries and so on were few and far between. And we didn't have modes of scanning the brain as it was operating to look at its function and its structure microscopically. And another reason that we thought that the brain couldn't change actually has to do with plasticity itself, something I call the plastic paradox, because the very same property that allows you to change the structure and function of your brain through various kinds of activities can, if repeated over time, strengthen those repetitions so much that the person appears, from a behavioral point of view, to be extremely rigid. So plasticity can give rise to problems as well. And of course, this view of the brain kind of had consequences in the culture. It meant if the brain, which people increasingly saw, was the source of who we are and our behaviors, if it couldn't change, then human nature would be as fixed. It meant if you were elderly and your brain was deteriorating, the idea of challenging it with certain kinds of, special kinds, not just any kind, of intensive exercises wouldn't really protect you from basically losing function. And it meant if you were injured, often there was nothing much you could do. If you had a stroke, it meant that people were told, basically, we'll give you some rehabilitation for about 6 weeks. And what that rehabilitation was designed to do was not to change the structure and function of the brain or get other circuits to take over from the dead circuits. It was just to kind of prime the pump. And so insurance reimbursements for things like physiotherapy gradually, it became normative for it to be about 6 weeks. And people were told, there'll be some improvement for the first 6 months to a year. Occasionally they were told maybe within 2 years, but really after that, it was a matter of grieving the loss of these functions. And of special interest to me, and in a way my initiation into plasticity, was that people who were born with certain kinds of learning disorders were basically considered, their fate was sealed from the very beginning. It was inconceivable that you could raise IQ in any way. Some people, many people, including people I respect, still believe that, but I've seen otherwise. And it meant that you had to try to compensate for the learning disorder. And so if you had an auditory processing disorder and you're a kid, you would get a note from a psychologist or a neuropsychologist establishing that and maybe there might be some funding for you. And this happened, like, for you to bring someone to class and write notes while the teacher was lecturing, or bring a tape recorder, and then perhaps a parent would transcribe that. So these were all compensations. And the general understanding, therefore, was over the long haul, your brain, after it's formed and fixed, the only change it can do is to deteriorate. And so it was a kind of, you use it, and over time you lose it. And neuroplasticity is really so important because it upends so much of that. And it says it's a use it or lose it brain. And your brain is more likely to waste away from underuse than waste away from overuse. And this was such a shock, in a way, to various aspects of the medical system, because so much of it was oriented to either compensation or propping up a failing brain with various kinds of medications and so on. So I consider this discovery, which was not made by me, was made by other people, but they were so disbelieved. I consider this the most important change in our understanding of the brain, since, I don't know, the discovery of the neuron or something that monumental. And what I've tried to do in my work is show the clinical applications, and really to try to create room for a field that you might call clinical neuroplasticity. And it turns out people are pretty receptive, actually, to this for a variety of reasons. First of all, one of the key reasons that plasticity was not appreciated was that the major way that scientists spoke about and understood the brain was as a complex machine with parts. And machines do many glorious things, but they don't grow new parts or reorganize themselves when something is broken. And you kind of just throw them out at a certain point. So there was a kind of cognitive set, shall we say, as to what the brain was. And that very much got in the way of certain things. And yet people had their own, because people did have plastic brains. We were always very curious about extraordinary things people did to develop themselves. And there are all sorts of incremental practices, and a lot of them are in the East, about a meditation or extraordinary things people can do with martial arts or ballet or gymnastics, where we kind of say, well, that's just talent. But no, it's something that people are developing, and that they can do feats which many of us kind of think are super normal feats. And a lot of that is a function of our plasticity. And so there was some receptiveness to it, even though it totally went against paradigm. And I would say now mainstream neuroscience talks about neuroplasticity. I mean, it's just been shown, and I can talk about some of the experiments in labs, and there's literally zero dispute about that. The problem is to make it helpful to people in their lives in challenging clinical situations. You really have to be, the devil is in the details in developing the exercises and doing that. And it often takes people 20 years who are working on a technique to know how to translate it into something that'll be efficacious for others.
And Dr. Doidge, you mentioned things like devastating injuries, stroke. Are there things where people just cannot experience neuroplasticity? Is there a bound of some sort that we know of?
Yeah, or at least speaking from where we are now. Okay. So, look, one of the reasons you can use plasticity to overcome some strokes, I'm not saying all, is, and this has been shown with brain scans, is you can sometimes get the opposite hemisphere to take over the function. The mirror part of the damaged hemisphere will sometimes take over, although usually it's areas that are around the damaged area. So there is some degree of adequate cortical or brain real estate that's required. That's one thing. Another thing is the brain does many, many things, and some of them, when they're damaged, lead to immediate incapacity, if not death. I mean, if your breathing center is damaged, like in certain kinds of injuries, you're not going to be able to breathe long enough to do an exercise, even for the breathing center. Although that being said, just so you know, there have been studies, and I talked about that, where even to some degree, the breathing center is somewhat plastic. But again, if it's completely wiped out, there's nothing you can do. The other thing is that most of the neuroplastic interventions that I describe at this point involve paying very close, concentrated attention to change a nerve circuit. You can't sort of half do it. I'm talking about change at a particular scale, like when someone has really lost, let's say, the ability to speak or something like that, and they have to do certain kinds of post-stroke speech exercises. They really have to concentrate. And that's because close focused attention turns on a part of the brain, the nucleus basalis, which is essential for initiating the kinds of differentiations and changes in the brain to develop new circuitry. I mean, that's a big demand, to go from no circuitry to new circuitry in general. Now, sometimes what the brain does is it unmasks connections that were already there that have been bypassed with newer ways of doing things. You know, we can often do things in several different ways. Like if you're trying to get, if I'm trying to get to Austin, Texas in my car, I can go by a map. I'm not talking about a Google map, but a map, and I'm looking at angles and straight lines and so on, and I develop a visual spatial picture of the general route there. But let's say I have visual spatial compromise, which a number of people do. Then I could go by landmarks. Not as efficient, but I could say, you know, go on this highway 25 miles until you see a gas station on your right with a red sign and turn right. That would be going by landmarks. And people who blow out the visual spatial system sometimes do things by landmarks or vice versa. So, yeah, the devil is in the details as to knowing what the limits are. And the other issue, some people think that this is a problem. I don't think it's a problem. I think it's just describing the way things are, is that many of the exercises, but not all, just so you know, but many of them do require a kind of relentless work for, let's say, 6 weeks at something, you know, an hour a day, or sometimes more, sometimes several hours a day. And so it's funny. Some people would say, well, that's a limit on neuroplasticity because not everybody can comply with that. And it's a fact that there are many people who don't comply with that. I think it's a leap or an extrapolation to say they can't. And I think one of the reasons they don't is because of the way we have come to think about medicine since the Enlightenment in particular. And, you know, so just an aside on this, because I think it's really, really important for a person who's trying to recover from a problem. You know, modern science began to use Francis Bacon, who was a great scholar and a very industrious person, hundreds of years ago, began as the conquest of nature to relieve man's estate. That was his term for it. And many people still speak of the conquest of nature, the conquest of space. It's a military metaphor, nothing against the military. Many good countries need militaries. But The question is, how appropriate is it? Now, it's deep in medicine. We speak of battling AIDS and conquering heart disease or the war against COVID. And doctors write orders, that's what they're called. And our therapeutic bag of tricks is called the medical armamentarium. And people after Bacon, talked about how we're going to burn off various diseases or poison them with our medicines. And that's led to this military metaphor in medicine has, first of all, led to a privileging of a kind of invasiveness. We're more impressed by a neurosurgeon who, at some level, cracks open a skull, or somebody who does a cardiac transplant. It's invasive. That's real medicine. Than we are at things that are much less invasive, or, God forbid, actually talk about using sensory stimulation that's not unpleasant, or even mental exercise to change something like the brain. So invasiveness has just tended at an emotional level to equate to seriousness. But the other thing that has started to happen, which is really, really important here in the military metaphor of medicine, is the two opponents in the military metaphor are the doctor, or the doctor plus the research medical establishment, versus the disease. And the patient, or the patient's body, is just the battleground upon which this great opposition unfolds. And so they're rendered passive. And on top of that, there's all the propaganda of a pill will fix it, and sometimes they do, but the expectation of having a pill to fix it, as opposed to something neuroplastic where the patient is absolutely essential in participating in the treatment. And of course, that's a challenge because, people with brain problems or learning disorders or chronic pain are often sapped and anxious and feeling defeated. And so you could characterize the fact that the patient is required to participate as a limit on the treatment, or you could say, from where do we get this idea that the only serious medical treatment would not really deeply involve the patient? We all know that in preventive medicine, there are certain things we as patients are supposed to do and take responsibility for. But once we're sick, the assumption of the patient role often coincides with an attitude of passivity, or it's easy to assume that attitude because we're so depleted by the illness. So, yes, to some degree, the fact that the patient requires a certain amount of grit for many, but not all of these interventions, is a limitation. Or maybe we have to do a field ground shift here and rethink what is reasonable to ask of patients with certain kinds of illnesses.
George, I'm hearing a couple of things that I think our listeners would want to hear pulled apart. One that maybe we can table is this idea of this intense attention, because with problems, it would seem it is harder to pay attention. With brain problems, it is harder to sleep, which then could affect the attention. So maybe we can table that, but come back to it. But I'm hearing you use a lot of language from the Moskowitz mirror sort of protocol, talking about this motivation and how sometimes people can be sapped and then they become passive and look to the doctor for the right pill or something like that. You use the word relentless, which is one of the R's in that protocol. So could we kind of talk through how that works, the Moskowitz protocol, the first one being motivation we've already kind of touched on, and then the next in the mirror is the intention. What is it about intention that makes it so important with these therapies?
If I could step back and just tell you about how, again, just to hear this out of the context of how Moskowitz was able to discover this treatment, may make it
please, you are a master
technical
storyteller. That would be great.
So Michael Moskowitz was a psychiatrist is a psychiatrist, and he became a pain doctor, a pain specialist. And so in the era that he became a pain specialist, there were really two groups of people who became pain specialists, who had already been specialists: anesthesiologists who would do all sorts of injections of anesthetics for people with chronic pain, and sometimes psychiatrists. I mean, pain is a subjective experience for sure. So, and he comes onto the scene in the era where there's already been one very, very important paper in pain. It's by Melzick and Wall. It's The Gate Theory of Pain. And it's important because it starts to hint that the brain is probably very involved in pain experience. So for hundreds of years following René Descartes, the idea was that if you have an injury to your foot, there are nerves, and they send a signal up which goes to the brain, and they make a report about how much injury there is. And these are accurate reports. So if you're feeling a lot of pain, you can assume there's a lot of injury. And it's a kind of one-way street from the injured limb to the pain fiber, which is sensing it to the to the brain, spinal cord and brain. And this paper by Waltz and Meltzer basically argued, but Wall and Meltzer basically said, we've discovered, reviewing the literature and so on, that there are various gates in this system all the way up. And for this gate has to be open for the signal to be experienced by a person as pain. But fundamentally, the consensus was that pain is experienced in the brain. And so if you give a person a general anesthetic or a local anesthetic, the signal doesn't get to the brain. And presto, it's proof that the pain supposedly is in the central nervous system. Anyway, Michael was out one day. It was, I believe, coming up the 4th of July, and he was in California, and he and a friend decided to climb up on a tank that was parked and was going to be used in some kind of parade. And at some point, he slipped and fell off. He's a big man, 6 foot, and a large man, and his corduroys got caught on some piece of steel sticking out of, and I mean, he was dying. His thigh got as big as his abdomen. And when the medics arrived, they gave him some morphine, and he basically said, double the dose. And they said, well, but we can't do that. He said, I'm a pain doctor. Double the dose or I'll be left with a chronic pain syndrome, I think was his fear. Mm-hmm. But while he was lying there, he said, I always wondered if I could tolerate what pain doctors call 10 out of 10 pain. And he discovered that he could. That's like being dropped in boiling oil, basically, for a pain doctor. And, but he also discovered he only felt that if he moved. And if he didn't move, his experience was the pain dropped to almost zero. And he said, my goodness, I've been teaching this to my residents, my students all the time, that there's like a switch, and it's really true. And then if they moved him or he moved the slightest bit, it goes up to a 10. And this is really important because it just underlines something that's very important to understand about acute pain. Acute pain, the pain system is a warning system, and it's designed to protect a damaged body part or a damaged person, basically saying, don't you move. And so, and you learn very quickly to obey that. And on top of that, we also have, that's a kind of sensory experience, but we also have a motor experience of guarding. Like if you stub your toe badly and you're at an arena, at a concert, and somebody is walking by, excuse me, I'd like to sit in the next seat. Like you're guarding and you're keeping that foot very, very still or pulling it back so nothing happens to it. So he discovered, like, firsthand that there really are these kill switches. Okay. Now, on another occasion, Michael was doing a kind of, I think it's a rubber tire skiing on the water thing with his daughter or daughters, and he flipped. And he basically had damage in his neck and back, particularly his neck, as I recall. And that led, over the ensuing weeks and months, to the pain spreading all the way into his back and on both sides. And what followed for him was an experience of chronic pain that lasted for 13 years. And it could, I think, as I recall, it could get as high as 8. And there were many days he simply couldn't work. And he's a pain doctor. So he tried literally everything. And that means conventional, like, all the various kinds of injections and so on, and nerve blocks and all of the pills. And he was on high heavy-duty pain pills. But, hypnosis and acupuncture and massage and every conceivable thing. And it really wasn't helping. It was destroying his life in many respects. And ironic, because he's gets up, and goes to a pain practice, and he's suffering greatly. It's around this time that he becomes aware of neuroplasticity, and he reads many, many thousands, tens of thousands of pages about it. And one of the things that he gleaned from all of this reading is the following. So we've established that acute pain is not a sickness. It's a warning sign. It's a protection. And the other thing that he knew as a pain doctor is that there isn't a single pain center in the brain. This is very, very important. There are pain centers distributed, for instance, through parts of the brain that otherwise handle executive function and planning, or higher math and calculation, which is why when you're in a lot of pain, you can't really do higher math or plan. It extends in part to the mood center. There is another separate pain area that's towards the back of the brain in the parietal lobe that processes various sensations, including visual sensation. And it might be hard for some people when they're in a lot of pain to do a complex visual exercise, imagine a building and a mirror image of the building, or rotating the building and so on. And it can affect the amygdala, which is often called the threat center or the anxiety center in the brain. That's not quite right. It deals with emotional extremes. And just as an aside, I'm going to mention brain areas, but as a shorthand, neuroscientists often talk about brain areas, and this is your music center or your language center and this, that, and the other thing. I want to underline that's not quite right. And we can get into why it's not quite right. It comes out of a model of the brain called the localizationist model, which has had many, many important accomplishments. I'm very glad we made those observations, but they tend to get extrapolated and overstated. When we say this is your speech area, usually what it means is it's a hub of a network. This is very, very important. And the network is kind of spread out. And to really understand its workings, you have to understand it's only a hub. So if I say the amygdala is, the threat center, I'm speaking just a shorthand, just to orient people very, very briefly. But actually, I don't believe it works that way. I believe it's been shown not quite to work that way. It's pointing to a truth, but it's not complete. And that turns out to be very important for issues of plasticity and recovery. So again, in a profound pain experience, it's not just that we feel pain. There's many, many other mental functions we can't do. And there were enough brain scans around for Moskowitz to learn the following absolutely important fact, that in many of these centers that do pain and something else, as the acute pain signal, which you could see on a brain scan, is the area lighting up, let's say just a little bit. Once it becomes chronic, let's say we're talking about the pain area in the parietal lobe, it would expand by about 10 to 15% because you're constantly feeling the pain, and therefore more cortical real estate is taken up for processing pain. And so there's a competitive component to plasticity, meaning no part of the brain is unused. The parts that are most active are the ones you're using over and over again. So if you're constantly feeling pain, that part of the map will expand, 10 to 15%, and that will be taking away processing areas from, let's say, visualization in that part of the brain. And so, in a way, there was enough insight into plasticity to see that the brain map for pain was actually growing. That's changing its structure and function to some degree at the cost of something else. So he had this idea. What if I relentlessly, to use that word, try to visualize every time I'm in pain? And he did it for several weeks, and I think he got just a few seconds release. But he just kept doing it relentlessly. And by 6 months, he's just vastly improved. And then he starts going off his medications. And then he treats his first patient, who was a woman he treated for a number of years, who was a nurse, who basically was lifting a 300-pound woman who was in hysterics with another nurse, and the other nurse was just overwhelmed by the hysterics and dropped her end, and that woman the first nurse damaged multiple vertebrae in her back and was inoperable. It was so damaged, and developed a chronic pain thing. And so she started to do the visualization. So what was the visualization? Well, he figured to keep himself motivated, he had to keep reminding himself that the brain could change and get worse. In other words, a way to look at this is a prime example, chronic pain, not of his neck getting worse or his body getting worse, but rather of his brain developing what we might call a disease process, or whatever you want to call it. Because it kept firing over and over, there was a hypersensitivity to the pain, meaning it took less movement to trigger the pain, and the receptive field, the part of the body that was being mapped by the brain map, grew from his neck to his shoulders and his back. So he started doing this, and gradually the field of pain started to go down. But at first he would just do it for many, 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 many hours, and nothing much would happen. And then about 2 weeks into it, he would notice brief periods where he realized, hey, I wasn't in pain. Okay, so he did the same thing with Jan Sandin. And then he started to do it with many other patients. And that's when he put together this acronym MIRROR, just to try to summarize what are the essences of doing it. Notice I haven't explained why visualization will work. We can get to that in a second. But just to finally answer your question. So M is for motivation. And yes, the patient is not going to be a passive participant in this process. They have to be motivated, and it's hard when you've been sapped by pain, which interferes with your sleep. And the other thing is, early on, when you're not getting results, you're not. This is just important to note. Why would you keep doing it? Well, because you hear these stories, you understand it takes a while. The next thing is intention. And so particularly in the early period, the intention is it's not to get rid of your pain. Because then you're just going to say, I just spent 2 hours visualizing and I'm still in pain. So the second thing is intention. Your intention early on, you cannot tell yourself, my intention is to get rid of the pain in this session, because that's not going to happen. Your intention is, in fact, to exercise the visual function, which will eventually take over or rescue the rest of the brain map from the chronic expanded pain map. And then you have to be relentless, which means so that's the MIR, every opportunity, every time pain comes up, you must start visualizing. Otherwise, you're going to lose those gains. And that means you can't just say, you know what, I'm going to work through this pain, which is very tempting, or try to distract myself from the pain. Rather, you've got to do those exercises. The next R is reliability. It's very, very easy, for all sorts of psychological reasons that I could go into, but I won't, to assume that when you're in chronic pain, it's a kind of a punishment. Even etymologically in various languages, pain and punishment can be related. It's a very human thing. It's also a human thing often when things aren't going well to assume, well, maybe I deserve it, or get into a very negative mindset about yourself and about your brain. My brain is really messed up. So reliability here means to understand that the brain is not your enemy here. Brains tend to often seek a kind of equilibrium, and it can get into an equilibrium or a stable state in pain. And you are going to give it the proper instructions through these exercises to get it into a non-chronic pain state. And if you do it consciously over time, eventually it becomes almost unconscious for the brain to just resume its pre-morbid functioning, its pre-pain state functioning. The next one is opportunity. And what that means is it's very similar to relentless. It just means you treat each eruption or escalation of the pain as the opportunity to attack it. I think that's actually very, very important, because the alternative is just to get demoralized. And I found that's helpful with other things, certain kinds of anxieties or obsessions. And then finally, the final R in mirror is restoration. And what that means is we are not aiming to manage pain. We are aiming to restore normal brain function. And so you're going to push through this. That's your goal. You may not achieve it, but that is your goal, to restore normal brain function. And some of his patients have been able to do that. A number of his patients have been able to get off all their meds, but not everybody. But getting off pain meds with their side effects and their addictive potential, getting to the lowest necessary dose, is very, very important. And it seemed to have so far worked with many different kinds of pain, like not just biomechanical pain, spinal pain. It's worked with some kinds of post-cancer pain, many IBS, different kinds of chronic pain. So even if the cause of the pain is something that's very well understood medically, once it moves into a chronicity, it could mean you have something that's still happening that's bad for you, but it also could mean that your brain has slipped into this centralized brain map problem. And so you want to try to, that's called wind-up pains in the literature sometimes. You want to wind down that wind-up.
And Norman, you mentioned opportunity as being especially important, and maybe even important for other types of compulsions. I'm curious about that, because one thing that often comes up with people who listen to this show is that they'll have some sort of relationship where then afterwards they have compulsive thoughts about the relationship. It was very difficult or abusive, and there'll be a traumatic cognitive dissonance is kind of what they call it. It'll be that their mind is holding the person as a good person and a bad person, and they find it exhausting to go through this. Can the opportunity attitude be relevant for dealing with something like that?
Yes, but it gets really complicated. So, for starters, like you've described a situation, a person's been in an abusive, say, situation, and then they're doubting themselves after, let's say, they're separating. But the first thing to keep in mind is, and we talk this way, and by the way, psychiatry's almost promoted that. We have the Diagnostic and Statistic Manual, and, we talk about these conditions. So that might be a PTSD, post-traumatic kind of condition, etc. But one of the most important things in medicine is, and this was first enunciated by William Osler, who was one of the greatest physicians ever to live, is that physicians don't treat diseases or disorders. They treat people with diseases or disorders. So you really have to know about that person. You have to know, like, was this the first time they got into this kind of relationship? Have they ever had, I'm going to use this, even though people don't like this word, but I think there's something to it, like a healthy, normal relationship. And then they had the misfortune of dealing with a psychopath who could probably fool anybody, including professors of psychopathy, as one professor of psychopathy famously said, or at least fooling them once. So what is their template as to, what their desired goal is? So, as a psychiatrist, I would have to know who this person is and what they've done before, and to begin to evaluate that. And so, like, when we talk about these repetitive ideas, there are many kinds of repetitive ideas. You can have one in the state of depression. You can have repetitive ideas in terms of anxieties. You can have repetitive ideas in OCD, which are very different and often seem bizarre to the person who's having those ideas. So rather than stray from the material, I would say that although in my day-to-day clinical work, I've done a lot of work on trauma, and those kinds of repetitive ideas are complicated, and I'll say a few words after. Let me start with what has been looked at most closely in terms of repetitive ideas in neuroplasticity. And that was the work of Jeffrey Schwartz on OCD. So, if I may. We all have worries. We worry because we're intelligent. And one of the chief things the brain is always doing, maybe arguably the chief thing, but I think that's overstating it, is making predictions. And it happens to be the case that there is a tremendous amount of uncertainty in life. And when there's uncertainty about important things, we're buffeted between hope, sometimes mindless hope, and fear. But fear can be mindless, or despair. And fear can be, at times, in a certain sense, mindless. But certain people, those who have OCD, can almost always be locked in certain kinds of worries. And the interesting thing about these worries is if the person isn't psychotic, they often experience these worries as ego dystonic. That's the Freudian phrase for it. It means it doesn't really make sense to them, which is in a way kind of a definition of a neurotic pattern. It's when part of you thinks one thing and another part of you thinks another thing, but the part that thinks or feels the other thing is very powerful. And there's an old joke in psychiatry. What's the difference between neurosis and psychosis? And in psychosis, 2 + 2 = 5. And in neurosis, 2 + 2 = 4, but it just doesn't feel right. And so in obsessions, I mean, I write about, a story of a man who he developed an obsession. I mean, it sounds like something out of a dream, that cars on the street, their batteries could spill battery acid, and maybe a little baby or a child would walk on the street and burn themselves. So every night he would go around his local streets with like a scrub brush, looking for little dots on the road and trying to scrub it off and neutralize it. And so he's obsessing about it when he's thinking, oh my God, there could be an accident and I'm not, a kid could get burned and I'm not doing anything. And then he compulsively has to go out and do that. And, there are many, many kinds of very common obsessions around infection, poisoning, and so on, where people become very preoccupied with these things. And we certainly saw how far this could go in COVID, where people are alone in their cars with their masks or alone on a beach wearing a mask. And these are either obsessional or anxiety neuroses that were developed and very much reinforced by the way people talked about it. And it's painful and it's tragic. So anyway, the kinds of things that people often obsess about might be passing on an infection or making some kind of mistake. I said such and such a thing to my boss. My God, I'm sure it was offensive to him. And then you could spend hours, and next week I'm meeting him or her to discuss my raise, and one could just worry. And now, maybe a lot of people would do that, but these people are doing this all of the time. Anyway, originally Schwartz was a behaviorist, and a lot of the behaviorist approaches to these things, let's say someone had a germ phobia, and I'm going to say something which, I don't know, you may not think is credible, but it happened. Like, even where I was working many years ago, someone, if they had a germ phobia, was told by the resident behaviorist to, and I'm not saying this goes on all the time, you put dirty underwear on their head to try to desensitize them to it. And there were various versions of that. And sometimes these things go on mentally, and you start thinking, if you have a phobia, you just imagine doing it and so on. And the goal is to try to desensitize. Now, Schwartz, who had also done a lot of meditation himself, I think that's important, grew uncomfortable with this. And then fairly early on, he was involved in doing one of the first studies of obsessive compulsives with a certain kind of brain scan. And what he discovered was, if they're active obsessive compulsives, there were 3 brain areas that were hyperactive during this bout of obsessing. And the first one was the orbital frontal cortex. Now, remember what I said about simplifying and saying things work in an area, but we're going to call that the hub. And it does many, many things. But one of the things it's thought to be heavily involved in is processing that mistake feeling. So you innocently spill wine on a fancy white tablecloth in front of your guests, and you get that mistake feeling, or you said something to the boss, you were a little bit relaxed and unfiltered, or whatever, and it sends a signal up to a part of the brain called the cingulate gyrus that is one of the areas in the brain that processes dread and anxiety. Now, if you don't have OCD, there's an activation of another area in the brain called the caudate. And once you clean the tablecloth or apologize to your boss, or call up the person you kissed when you had an infection and say, "Are you okay? I realized I had a COVID coming on," or whatever. It kind of turns the page, and turns off the dread and the anxiety. But in the people in OCD, it was hyperactive. It wasn't working. It was sending signals, but the page wasn't turning. So he developed a kind of cognitive, you could call it a kind of cognitive behavioral intervention, but I don't think that's quite right. I think he developed a kind of mind-based intervention with a lot of psychoeducation as to how the brain is working, where he would basically show these brain scans to people, explain what's happening, and explain the following thing. Let's say you're worried that you didn't turn off the stove, a kind of typical thing. So you have trouble leaving the house because you keep going back and checking the stove. And there's certain people who can't get out of the house for an hour, or did I lock this, and so on. And you're obsessed, and then you finally leave the house and you're still obsessing about it. Even though you kind of, while you were anxious, turned it off. He would say to that person, you know, what's happening is you've got this mistake feeling. You're not sure you turned off the stove, usually because you're so anxious about it, you weren't actually paying attention, and you didn't feel it touch, and you didn't look that it couldn't go further. Then you get the anxious dread feeling, and you can't change the page. And one of the reasons you can't change the page, this is a neuroplastic component coming in here, is because the way you handle that dread is to go and try to turn the stove off again, which lowered your anxiety for a second, and then that is rewarded in the brain. And you're basically teaching yourself the way to make the problem go away is constantly going back and turning the stove off. So you actually reinforce the OCD pattern. You're giving yourself a reward for it. And so he basically said, the first thing you do is you've got to stop doing that. And so he would do various kinds of things. That the first thing is you have to relabel the problem. You know, your problem is not the stove, or it's the OCD. That's not me. It's my OCD. And then you have to realize why it's important not to check the stove, because it's actually making it worse. And sometimes you will have obsessions where it's not as easy, because it might just be an obsession in your mind. There's not a compulsive component to resist. So then you have to be prepared to think about other things or do other things, garden, watch a podcast, and constantly try to stay tuned on the podcast or the gardening, and not let your brain indulge the obsessive thought. And basically what he found, and these were very, very severe obsessives, is over time, if they did that, so they took every attack of OCD as the opportunity, we're now back on the similar ground as Moskowitz, and they were relentless, they could really wind it back. And I've been able to use that technique with some people and help them. You know, there's a whole spectrum of obsessive compulsive disorder, and I am not saying that absolutely everybody can be helped all the time, but I went down and spent time with him and joined the groups that he ran and so on. And I definitely saw that some people were being helped. And often they were most helped by looking at the brain scans of before and after. So we're back to what this visualization mystery is about. And because that allowed them to stay motivated to do it. So just to pick up on how visualization might be helpful here, if I may,
Please.
for the Moskowitz thing. There was work done that I cover in the brain that changes itself. There were a number of sort of aspects of this which showed that, for instance, if you look at the letter A, or you imagine the letter A, the same brain hub is activated. And so I have a whole chapter on imagination in the brain that changes itself. And I go over many of these experiments where sometimes doing something or imagining doing it activates the same brain area. A very famous and important experiment was done by Pasqualeone, where he basically had people sitting at a small keyboard with musical notation, and they had to learn a particular song pattern. And he divided them into a control group that learned it and played the keyboard, and another one that just did mental practice. And basically what they found is that those who only did mental practice got very, very good at it. Not quite as good as those who did the physical practice, but if you gave the people who did the mental practice just 1 hour session where they could put together their mental homework with their actual physical work on the keyboard, they pretty much caught up with the people who did physical practice. And, Glenn Gould, for instance, who developed a problem with his hands. It's actually also a neuroplastic problem. At a certain point in his career, a lot of his practicing was just mental practice. The great Canadian pianist, Bach performer, and much more. And so I go through many of those kinds of experiments. So visualization, which, many athletes also use, it's not trivial. So you can actually activate those networks. Now, it's really important to separate that out from that kind of mental practice, which is a lot of work, from saying, if I just think positive thoughts, and I buy this lottery ticket, maybe millions of dollars will come to me. There are people who are very prone to naive wishful thinking who extrapolate from what I'm talking about. No, what I'm talking about takes work. So back to Moskowitz. How might visualization actually be so profound? Well, one of the things that's really important here is that to understand that we have our bodies, and then we have our mental body image of our bodies. And we actually project our mental body image onto our body. And if our mental body image is pretty realistic, we can't even tell the difference sometimes between our mental body image and our body. But there are people who have radical differences. I mean, the example of anorexia nervosa, someone who's very, very thin, looks at herself in the mirror, if she's aware it's herself, and says, "Oh my God, I'm so fat." Her body image is totally disconnected in a way from her real body. But we all have body images. And sometimes it can change when you go to the dentist and they freeze your gums or to do a cavity. Sometimes you can feel like your whole cheek is really, really big. There are many examples of this, and we tend to just forget them because most of our experience most of the time is there's some kind of synchrony of our body image. It's important to understand that the body image is a composite, and it was first, the term was first used by a student of Freud named Paul Schilder about 100 years ago. And the body image is composed of our observations in the mirror, our sensory data, very important, but many kinds of sensory data, like our pain sense, our proprioceptive sense, where our bodies are in space. And it's very much colored by our emotional state at the moment. Sometimes we can feel buoyant and I don't look all that bad. And sometimes we can feel, oh my God, why would anybody keep me around if, we're in another mood? And it can even be supplemented by things we learn about our bodies, like an X-ray or a brain scan can be incorporated if there's something we fear is bad in there, and so on. That's me too. So the body image is a very dynamic composite. So let me tell you about a couple of experiments. Lorimer Moseley is an Australian pain researcher, and one of the things he did working with people with hand pain is he explored whether the body image could have an impact, that visualizing the body image in some way or other could have an impact on the hand pain. So he got people with hand pain, he got a group of them to just do certain movements with their hands. And remember, their hands hurt. And then he did things like he had them look at their hands, through binoculars where their hands were enlarged, and they registered more pain. Then he flipped the binoculars down so that they were looking at their hands as though they were shrunk, and they were now visualizing them that way, and the pain was less. And so you could say, well, it's all subjective. And yeah, but there's an aspect of pain that is arguably subjective. And then he did something else, which is when they were looking through the binoculars, enlarging their hands, because they were in pain and they often had inflammatory causes of the pain, he could measure the swelling in their hands before the binoculars and after the enlarging binoculars. And lo and behold, the swelling increased too. So that's really interesting. It's telling you that the body image, the visual body image, is actually having an impact on the actual limbs, but also on our experience of the pain. A second experiment that was done in Nottingham, England, involved the following. It was at a fair, and these were scientific researchers, and they were exploring a certain kind of virtual reality experience, shall we say, or modification of reality experience. And they had this box, and the kids would stick their hands in both sides of the box, and there were cameras in there, and it displayed what was happening on a big screen that they could look at that enlarged what was happening. And the algorithm was such, so if I take my finger and I can actually pull it and stretch it a little bit, and I can bend it a little bit. But this visual algorithm made it such that if you stretched it, it would look like it was stretching 3 times by amplifying certain things. Or if you're bending it, the angle seemed much more extreme. So the kids are horsing around and having a lot of fun, and several kids were brought by their grandmother, and she said, "Can I try?" And so she's about to put her hand in the box. She said, just to the experimenters, "Just be careful. I have a lot of pain and arthritis. Be gentle when you're stretching my fingers." So she did it, and she said, "That's strange. My pain went away. Can I take this home with me?" And that caused the researchers to have to do a real heavy-duty rethink of what was happening. And interestingly, a bit different than the Lorimer experiment, for a number of people, they did a control study, and when they would stretch the finger, the pain would go away. In others, when they would kind of compress the finger, the pain would go away. And others, if you stretched it or compressed it, it would go away. And they spent a lot of time trying to figure out why that is the case, because it seems a bit different than the findings of Lorimer Moseley. But one thing for sure that's a takeaway is that the modification of the visualization, which of course we know is taking place inside the head in the body image, is having an impact on pain. One way to understand it, and I can't unpack all of this here, is certain experiences kind of freeze in time in the brain, and as in PTSD, and lock in. And it may be that just showing the brain, if you will, or the mind, that the body image is modifiable can unlock it's hooking up with the pain. So now we go back to Moskowitz. And the person sitting there in pain, or Jan Sandin is patient, and they're looking at the brain in acute pain, this much, in chronic pain, this much of the brain map, and in no pain. And they're trying to imagine going in that direction. So the point is they're visualizing, which means they probably could visualize many other things than that, but this is keeping them motivated. And it's very, very clear that there's some relationship. And remember I said that many of these brain areas are dual processors. In fact, they're multiple processors. But there actually are visual tactile cells in the brain, which kind of makes sense. Cells that specialize in both touch and vision at the same time. So, look, we've known for a long time that hypnotists can often take people who are in pain and get them to imagine the pain area shrinking. And if they're in a hypnotic state, it often works. The problem often is it doesn't always last. It doesn't last as much, certainly in Moskowitz's experience, who was also trained in hypnotism, as have I been. And but this is working differently. If you do it initially, you're getting very, very little reward. But over time, it can disappear completely. And so, the obvious question is, well, isn't this just the placebo effect? And the placebo effect is very, very strong and extremely well documented and very specific. Like, if there's various ways of looking at the brain while it's functioning with scans. There's even micro little pins you can put in the brain, like in Neuralink. There's many, many ways of seeing how brain maps are firing. But like we know from various kinds of brain scans that when a person has a placebo response and a certain, let's say, part of the body is hurting, and the pain goes away, that part of the brain map clears up. It's very, very specific. And there was an experiment that was done where a placebo, for people with the pain, a placebo cream was just put on one finger, and they had the person scanned before they put on the cream. These are usually controlled experiments, like sometimes there's a real cream, sometimes there's a placebo cream, and so on. So the person was scanned, let's say their middle finger was sore, it would show up on the middle finger processing area in the brain. And then they put the placebo finger, they cover it with the magical placebo cream, which is really just nothing. And that very precise area goes down. So placebo is very real.
Yeah.
And it relates to everything I'm saying about imagination. We call it imagination, but that kind of implies that it's trivial. It's not trivial. I mean, many of the most important things come out of this, if I was to say, imaginative, hypothesizing, predictive function of the brain. It sounds more technical, but that's a lot of what we're doing all day long, right? But the reason he thinks it's not placebo, it just because he's done pain medicine for 40 years, and placebos, although they often act when they act very, very quickly, they don't last as long. And these kinds of exercises, when they work, they get better as they go along, and at a certain point, you no longer have to do the exercises, in the optimal outcome. I'm not saying this will work for everybody all the time, but after my book came out, I certainly had a number of people. My book is not a book on how to heal your pain, but I certainly had a number of people who had read the chapter and used it. And people can go to Dr. Moskowitz and Dr. Golden, who he worked with at the time he was developing very advanced versions of this, have a website called Neuroplastics. So Neuroplastics, it ends with an X.com, I think it is. So again, the fact that it's visualization, it makes a certain amount of sense. But other senses can be used. Vibration sense can be used. Certain kinds of motion and body workers who have helped. Various, by body workers, I mean osteopaths, Alexander workers, Feldenkrais practitioners, and so on, have at times known that you can address certain kinds of pain by various kinds of movements. And of course, there's other kinds of pain that are being caused by bad diet, causing inflammation, and so on and so forth. I'm not trying to be exhaustive by telling these stories. I'm not claiming. I loathe this idea of finding, just a condition or a group of symptoms and saying this is the treatment. That is not the way to think about medicine. But what I tell a story, I elaborate these particular case histories. They're not anecdotes, they're not two-line things. There's a lot of detail in there because they're not anecdotes. They are anomalies for those who believe in the doctrine of the unchanging brain. They are challenges, and there is a long, rich, important history within neurology and psychiatry that some of the greatest breakthroughs came from case histories. Maybe the greatest breakthroughs. I mean, HM was a man who had epilepsy, and he had his hippocampi, which are hubs in the brain that turn short-term memory into long removed. And it's possible we learned more about how memory works through understanding the effects on HM than thousands of studies that had been done. And we learned about the frontal lobes from the story of Phineas Gage, who was a railway worker, who was a good colleague to have, who had a steel spike in some kind of explosion was driven up through his frontal lobes, and he became intemperate, unreliable, irascible. And we learned a lot about the moderating functions of the frontal lobes for emotion and so on from him. And there's Oliver Sacks's beautiful, painful, tragic story, but beautifully helpful story in understanding aspects of object and recognition in the man and recognition of people in the man who mistook his wife for a hat. So, again, the plasticity stories here are hardly anecdotes. As V.S. Ramachandran, one of the most brilliant neurologists alive,
yes,
who often, and he himself made major contributions to understanding pain, said, but by often doing single case histories and then repeating them, said, there are certain kinds of skeptics. And he said, if I carted a pig into this room and said, I can make this pig talk. And then he said, no way. And then he waved his wand and the pig talked. Would it be an appropriate response for the witnesses of that to say, well, that's all very well, but that's only one pig. Make 5 more pigs talk. Or would this be a case of people who call themselves skeptics, but they could use a little more skepticism of their own skepticism and start using a little bit of common sense and care a little bit more for the love of the truth as opposed to their current model?
And it seems that with the work that you do by telling these stories, as you mentioned, people gravitate to things like stories or examples, and then it gives them things like hope. How important do you think hope and self-belief really are in the process of making neuroplastic change?
I think it depends on the condition. And so, yes, but it has to be what I would call mature hope. So, many people, this was the philosopher Spinoza. He begins one of his books saying that in uncertainty, human beings tend to swing between hope and fear. And again, I would add despair. And so for a number of these conditions, because the model was, there was this doctrine of the unchanging brain, many people were told in pronouncements, there's nothing you can do to get better. And again, historically, there had been examples of people with strokes who got better after a year, after 2 years, but that wasn't in paradigm, so it was just ignored or disbelieved. And that gave rise to what I call the neurological nihilism. But there's a tendency, some people, I think it was Saxon who might have said that, neurologists basically became very, very good at describing catastrophic illnesses in almost luxuriant prose, but not all that good at a certain point at treating many of the conditions. And that's not an attack on it. I mean, when we're talking about chronic degenerative brain disease, we're talking about something that's really, really serious. And there are things neurologists, of course, can help. But about many conditions, particularly things that had a chronicity to it, there was a lot of despair. And one of the things that these books, I think, have done is shown that sometimes this is unwarranted. So, look, we all know that human beings are prone to false hope. Even people who are prone to false hope they've had many experiences with it. So they say, I hope I'm not being wishful here, but I think, I have a feeling this is going to work. But there's a situation which didn't have a word for it in the language, or a term for it, and so I coined a term, false despair. And so false despair is basically a despair that arises when, someone who's got a pretty troubling problem is told sort of in no uncertain terms, based on the doctrine of the unchanging brain, you can't get better. And so here's the problem. False hope tends to be short-lived because in many of these situations, brutal reality intervenes pretty quickly and brings you down to earth. But consider false despair in a situation where someone is, let's say, as many have been in the past, had a stroke that affected, let's say one limb. I'm not saying a totally devastating stroke that's affected 10 different things, and they were told, you've got six weeks of physio. That's what your coverage is. And by the end of the first year, you'll get back all you're going to get back. So that person, if they're well brought up and compliant and have a certain amount of humility, saying, I didn't train as a physician or I didn't train here, might just do that and stop doing intensive physio, the likes of which I document in The Brain That Changes Itself and in The Brain's Way of Healing, is pretty intense for a significant period of time. Well, any residual function that's there is likely in the use it or lose it brain to further atrophy, and they won't get that back. So the effects of the false despair could be long-lasting and not self-correcting. So, but these are not trivial, many of the things I describe, they're not trivial problems. They are serious problems, and in some of them, you don't get a yield for a period of time. And so if they have immature hope going into it, I've always had a positive attitude, and they don't understand that it's often more of many of these things are a marathon. Not all of them, by the way, but many of them are more of a marathon. Some of them, there's a lot of things that can happen in 6 weeks, by the way, if you are doing the right intervention and you know what's going on, like in phantom limb pain or some of these things like that. But others, to build up areas that had never been built up, like in kids with learning disorders, you're often talking a year or several years for certain things. So I want them to have a mature hope, meaning not neurological nihilism, but understand it's often not a quick fix. But the thing about hope at the simplest level is it seems that the way we're framed is we have to have a plan and a goal to motivate ourselves to do work, which is not always pleasant. And so there is a need for some degree of hope. But I'm not talking about an amorphous, diffuse hope. And at some level, it's not based on faith, because you don't know the outcome, because there are many things. I mean, let's say you're doing something like a TBI, there's 150 different areas by cell type in the brain, and in a TBI, you could be hit here and have diffuse injury here. I mean, and one person with a TBI had a high IQ and never did drugs or alcohol, and the other person loved dangerous sports, had multiple concussions, was on all sorts of drugs all the time, and so on and so forth. You don't really necessarily predict outcomes easily. And so as a clinician, when someone is considering undertaking something, and if someone asks me my opinion, I never say this will work. I explain to them how it works. Usually people can understand roughly. And then I say, if I believe this, I think it's in the category of worth a try. And this is actually something that's very, very important to me, because my first book dealt with many different kinds of conditions, learning disorders, love, addictions, psychoanalysis, a girl with half a brain who was functioning and nobody could believe it. I mean, many, many different kinds of neuroplastic. In some ways, I would call them unanticipated outcomes, or some people might call them marvels. And there were only a few cases of brain injury in there. One of them was post-chemo radiation. And I was inundated when the book came out with calls from two different groups. One of them were people who had different kinds of interventions who said, I think my intervention's a neuroplastic intervention. And sometimes they were right, and other times they were just rebranding themselves. You got to watch for that, because it started to become a word that people were throwing around. And then I was contacted by the relatives of, or many people who have had certain kinds of what are called mild traumatic brain injuries, meaning, well, there's nothing mild about them usually, but it means they're not in a hospital bed in a coma. And most of these people had, can't work, couldn't work. And most of the interventions, quite reasonably, they weren't covered by insurance most of the time, because they're so cutting edge, were costing in those days $5,000, $6,000 an intervention. And I'm thinking, well, which of these many interventions I've now learned about might possibly help this person? Because they might have only one or two shots at this. They're broke. And so the second book, which I did not intend to write, but came out of that problem. And so I developed what people were using neuroplasticity to describe every conceivable kind of change that could happen in the brain, which was problematic. So I called it the stages of neuroplastic healing, and to try to give, first of all, myself some guidance as to what to suggest to people. And the more I got acquainted with these stages, the more I realized that they are all different. They're all authentically, properly differentiated, but you don't always have to go in the same order. But there's a general order. In the first phase, is attending to correcting general cellular functioning of the neurons and glia, which are supportive cells inside the brain, so that if a person is exposed to some kind of toxin or their brain is hyperinflamed, which, by the way, happens in a number of brain problems, including, not just in things like multiple sclerosis, but including there's some kind of inflammatory abnormalities after stroke and even in TBI at times and so on. So you don't want to be training cells that are quite sick if you can remediate those. And then the next thing is, in the brain that changes itself, I elaborate that in many brain problems, including stroke originally, a person has a stroke, they try to move the limb, and it doesn't move. And so the brain learns it doesn't move. But sometimes it doesn't move because there's this diffuse crisis in the brain that's post-stroke that has to do with bleeding, reabsorbing the blood, reabsorbing dead tissue, and so on. But in that window, which lasts about 6 weeks, we've known about that for over 100 years, they try to move it and they learn they can't move it. So one of the things that happens is not all the cells are dead. Some of them are dormant, others are firing irregular signals. So for the cells that are just dormant, we want to find some kind of neurostimulation. And again, you can use thought, movement, sensory experience, and various kinds of energy inputs to the system. And then the next thing you want to do is, because some of the cells are not functioning or functioning poorly, there's like sick cells, they're firing irregular signals. And so you have to modulate the brain, and that's neuromodulation. And often after you do that, the person with a brain injury or a brain problem, even a kid with an LD, will often require a lot of sleep, and that is a normal thing, neurorelaxation. Remember, let's say you have a learning disorder or any kind of neurological accident. Often it's very hard to process what's coming at you in real time, and you go into a fight-flight that can last for months. So they need that neurorelaxation. And then, now that the brain is relaxed and modulated and healthy, or healthier, then you do neurodifferentiation exercises, which you're teaching the brain map to make fine distinctions, some of which it never may have made, or it once made, but lost it. So here's what I mean by that. It's a use it or lose it brain. And if you host some kind of problem, let's say it's a stroke or whatever, you're not using a brain map. It goes from, let's say it's a motor map. It grows from being able to process very differentiated fine movements to a map that's non-differentiated. I mean, compare a Google map of the United States to, I don't know, what the first explorers wrote, or something. If you were to draw something on a napkin, you lose the fine details. So to get the brain functioning normally again, you need to give various kinds of differentiation exercises.
That neuromodulation phase and the neurorelaxation, they seem to go hand in hand, and it seems to be a lot about getting into a parasympathetic state and affecting the reticular activating system. How does that work? How can that be approached?
Well, let's again put the microscope sort of on low power. One of the things that's defining about nervous tissue is it's irritable and excitable.
Yeah.
It can respond to stimuli, but it can over-respond. And so there are also cells that inhibit these excitatory cells, and they're inhibitory cells. And for instance, patients with traumatic brain injury very frequently are hypersensitive to light, to sound, to being touched. It's like all their neurons are just firing too much. So just looking at this from low power, you don't want the brain environment to be hyper excitable. And many of these people can, by the way, have epilepsy, which is just like a storm of excitability. You have to restore the balance between excitation and inhibition. If you think about, for instance, vision, we have the ability. There's some kids at summer camp, right? 6 hours from now, under the covers, with a fading small penlight battery flashlight, reading a comic book in very low light, or going to Miami, in the middle of June, and be exposed to all of that magnitude of light. And some of it has to do with the pupillary reflex, but there are other components to the visual system that are like a dimmer switch. So we're always having to find that sweet spot of excitation and inhibition. Now, there's also a system, the reticular activating system, which arouses us in the morning, wakes us up, it's part of that, and gives us higher conscious awareness and affects us, and then we have a different situation in sleep. And then there's the sympathetic, parasympathetic balance. So the sympathetic is the fight or flight, and it's, we're ready for battle, and we have energy going to our muscles and our heart and so on. And then we have a system that is antagonistic to that, or turns it off, which is the parasympathetic, which is rest, digest. It's also activated in lovemaking, but also healing. So considering that many people with brain problems are very worried, very much in fight or flight, having trouble processing reality in real time, they don't have access to normal amounts of parasympathetic. So yes, a lot of the interventions are ultimately helping the person to get into some parasympathetic. And sometimes knowing that there actually is a treatment and a goal is going to help a person move out of some of that hypersympathetic arousal, but not always, because it depends on what they're dealing with. So, and by the way, I know we live in a sort of tech fetishizing world, but people who study the brain very well, like Steve Porges, and study these systems, say, the best single regulator of the nervous system's balance between sympathetic and parasympathetic is another human being that has good faith towards you. So, and that's really important in the clinical situation. So all of these things go together. Some of the interventions, I haven't spoken about light therapy, but can be very, very powerful for certain things. We often see people go into a parasympathetic pretty quickly, and I described a device that's used on the tongue to talk to the brainstem, and people seem to move into a meditative state very, very quickly there. It's called the pons, and that's written about in both books, but particularly the second book, The Brain's Way of Healing. So, yes, it's essential to get there at some point.
And Dr. Doidge, just a couple more questions. We talked earlier about attention, and what I'm hearing are a lot of things that could make it harder to pay attention. We mentioned with the pain that it can take up more space in the brain and make it harder to concentrate, perhaps, the sleep issues. What can be done to maximize the attention necessary for neuroplastic change?
Again, it depends who we're dealing with. But first of all, it's nice to have a win. Meaning it's nice to have, when I'm thinking of the various, if a person has a problem where they're going to need several neuroplastic interventions, I do think as part of ordering them, where are they likely to have a win, just so that they can, it'll help them with their motivation, which is, of course, is going to relate to their attention. Part of it, so much of it is just giving them accurate information about how neuroplastic change occurs, and how like the light therapy doesn't require attention at all, but in those that involve exercises, I mean, there are all sorts of experiments that were done, animal experiments, not just human experiments, where the creatures involved do something where they're being distracted versus not distracted, and you just don't get the kind of lasting change because you're not firing up the proper circuitry to do that. And there are other things to be explained here, like in my chapter on imagination and the brain that changes itself, I show how if you're doing like an hour's exercise, let's say Monday to Friday, and you're doing a brain mapping, and you're, let's say, trying to learn a skill like playing the piano, you will get significant changes by Friday, but the following Monday, most of them will have dissipated. But if you do the same thing for 6 months, they won't dissipate. So you need someone, again, who knows the details so that you have an accurate sense as to whether you're moving in the right direction, and you don't overinterpret the fact that when you go back on Monday morning and try it again, you don't have the wrong expectation that you'll be maybe a little bit off Friday's achievement. You have to understand that. And so that gives guide rails to the person. And in most of these conditions, they're so problematic that if you know what you're talking about, and they understand how it's working. So I'm not talking about young kids here. There's a lot of internal motivation to get better, and therefore to pay attention. And people just feel so much better, as well as as everyone knows, when they're not on their phones and not constantly distracted. So you have to have a protected environment.
Mm-hmm. Yeah. Well, Norman, before we get to our last question, where's the best place for people to look for you online?
Well, I guess my website, but because I'm doing other work right now, I'm not doing a lot of talks at all or whatever, but at some point I may be. And at a certain point I was inundated with a million clinical questions that I couldn't possibly keep up with it. It's just not humanly possible. At a certain point I was answering everything, but I find that I can be most helpful by recording in a hopefully clear way what people are doing, and they can approach many of the people I've written about directly. What I've tried to do is see how all these things fit together. And I've really put much of what I know in those 2 books.
Definitely. Yeah. We'll put some links to your website and to your books in the description for everyone to check out. And last of all, Dr. Norman Doidge, your second book is dedicated to Karen, my love. What has neuroplasticity taught you about love and relationships?
Oh my God, that is a big question.
Or maybe a highlight.
Well, I mean, a number of things, I guess. Well, I think when there's a successful love, there's a real melding that happens between the 2 people. And of course, as I said earlier, this sounds, uncomfortably clinical, but a human being who has love and who is loving, is probably the single most calming, nurturing presence and creative platform another human being can have. But if we are to get clinical, there were a number of things that Freud pointed out that people had so much trouble with. And one of them was the formative aspects of childhood. Freud was arguably the first person to understand that neurons that fire together wire together. He proposed that. He called it the law of association by simultaneity. And what he meant was when one neuron fires with another one simultaneously, they will form a link in the brain. So this is, 50 or 60 years before Donald Hebb proposed that idea. Many neuroscientists don't know that Freud was a neuroscientist, and he had proposed that. But one of his, if people kind of know this, that he thought that childhood attachments are formative, that they're extremely formative, compellingly so. It's not that he didn't think there were other factors in terms of heredity, which was the term they used in those days. But, one of the things we learned about plasticity is that, people used to say, well, if you learn a language in childhood, it's easy, but as an adult, it's very hard. One of the things, so they were noticing that without knowing about plasticity, and then various experiments were done by Hubble and Weasel that showed that if kittens weren't exposed to visual information in their infancy, they didn't wire up the visual modules in their brains. And so they argued there's a critical period of plasticity during which you have to get input. And that became widely accepted. And that helped to explain a lot of things, including Freud's notion that childhood was particularly formative, but also Konrad Lorenz's experiments with, ducks or goslings or whatever that would attach to him if he was in place of the mother, in the first decisive window, and so on. So critical period plasticity gave a lot of validation to a lot of Freud's concepts. And I see a lot of that. I think it's true. Now, I think the first podcast I saw of yours that I was very impressed with was a gentleman talking about the genetic components of narcissism.
Yes.
And interesting, and because people talk about it almost solely in childhood traumatic terms often. And I think sometimes that is true, but I don't think it's always true. Just as an observer of human behavior who's been around for a number of decades, I have seen instances of lovely parents who've raised several very, very compassionate, engaged children, and another child who's extremely difficult. I don't think who didn't really have much of a different upbringing. So you can't be all or nothing in these things. So point taken. And Freud himself thought that psychoanalysis was not especially good with narcissism, interestingly enough. But then people started to apply new concepts, and some people made some headway, but I have not been radically impressed by it myself when I've seen people who are specialists in it and their outcomes, which isn't to say it's never worth a try. I'm just saying I think Freud thought was a bit closer to your guess, perhaps, than some people are aware of. But that said, the history of one's attachments, for most of us, is extremely important alongside genetics and leaves its traces. And many, many people are endlessly caught up in repeating certain kinds of traumas and difficulties in childhood. And it really helps if you've experienced love to begin with, and a loving family and a supportive family. And in the chapter called Acquiring Tastes and Loves, I go through the evidence for early childhood attachment affecting adult experience and some traumatized patients, and how when they got to that, they were able to really move beyond it. And The Brain That Changed Itself, I think, was one of the very first books to signal us a serious warning about internet porn as potentially hijacking sexual tastes. And I won't go into the arguments. I just explain exactly how that works and neuroplastically interacts with the reward system, but also unresolved childhood complexes or other kinds of complexes that help to explain a lot of the content of porn, which is often very much at odds with what a person feels they would endorse as ideal behavior. They can get hooked on it. But it also anticipated the whole problem with cell phones and attention. And so when the love is going well, I mean, I think it was Chesterton who said, happy marriage, heaven on earth; unhappy marriage, hell on earth. Mm-hmm. You can either end up in a vicious cycle or a virtuous cycle. And those virtuous cycles really do facilitate things. And it just in passing, one of the things I mentioned in that chapter was, I mean, even if you think of a healthy monogamous couple that's maintained their sex life over decades, it's interesting because they don't look usually, in their 60s or 70s quite like they would look in their 20s or 30s. But yet their brains actually can adapt to that because there have been so many, hopefully, rewarding experiences and pleasurable experiences together that they begin to equate that person with joy and satisfaction. There's a story told by Stendhal, a very naughty man in some respects, but had a lot of experience in a certain kind of love. And he recounts how interesting it is that if a person fell in love with a person with some kind of lesion, or which might have been called a beauty spot, but it might have been a pockmark or whatever, and they could, after a while, not only not see it as marring their face, but just delight to see it. So there you have, it's like an acquired taste, where, and it's reworking their image of the other person. So yeah, plasticity is operating even in love, thank God. And ideally you want a partner who's allowing you to grow and explore that.
Well, that's a beautiful note to end on. Dr. Norman Doidge, thank you for doing the work to bring together these stories and to package this field in these beautiful stories that the rest of us can understand and that we can find hope in, we can find belief in, and for taking this interview with me. Thank you so much.
My pleasure.
Thanks for watching my interview with Dr. Norman Doidge. To go even deeper on these ideas, you can watch my episode with Dr. Peter Salerno using the link in the description or the box on the screen.